doing its usual.
There we go. I think we are now live. So welcome everyone to this evening's meeting of the Health and Wellbeing Board. Welcome to all of you. We have a few new faces, I think. But we have a very busy agenda, so I don't propose that we do introductions now, but I think as people come on, if they can introduce themselves for the benefit of colleagues and for anyone watching along, that would be really helpful. So that we do have a really tight agenda. There's some rather large updates, very important updates, and we will try and get through them as quickly as we can to fit them all. So I'll kick off, and if everyone could just remain muted while not talking, that would be wonderful, because there's a little bit of noise from somewhere. So I haven't had any apologies from absence, Keith, unless you've received any.
No.
Fantastic. There is an urgent item, 7B, which is the Better Care Fund update, but we will come to that at the appropriate point. Does anyone have any declarations of interest they would like to make or need to make? No, excellent. There are no matters to be considered in private, so we move on to the minutes. Are we all happy that the minutes of the 16th of March are accurate? Wonderful, excellent. So Daniel, I can hand over to you for the Health Watch update.
I'm just going to try to share my screen.
Keith may need to let you.
Let's see if it works.
I've done that bit.
Brilliant.
How's that look?
Perfect.
Fantastic. Thank you so much for having me. First Health and Wellbeing Board, so apologies for the nerves. Two documents to present. The first is our Q4 patient experience report, and the second is a smaller engagement report that was done last year. For patient experience, our target is always around 1,200 patients, which we surpassed. Good cross-section of age, diversity, background, religion, ethnicity. The largest kind of discrepancy was between women and men, with 68% women and 31% men. Kind of main highlights. When patients are seen by their doctors, we get really positive feedback. Treatment and care is really good, upwards of 70 and to 75% positive. Where we see issues improving is around appointment availability and access. While we did get a lot of negative feedback, even the negative feedback included a caveat of, well, it's improving or it's better than it was last year. So we're hoping this trend continues as we work our way out of the pandemic. What was unfortunately negative across the board was hospital wait times, which I doubt anyone is surprised by. One thing that was worth mentioning is 90% positive with dentist services. This may be a slightly inflated number because as it currently stands, we're looking at people who have used their dentist recently and have access to an NHS dentist. Last 2 points I want to highlight regards to the patient experience is during the fiscal year of 2020-2021, our diversity background was already representing at 25%, whereas this most recent fiscal year, that jumped to 50%. And while we're really happy and glad to see that breadth of representation, we do have to acknowledge that a large group of people kind of dropped off the radar for us while we were doing our patient experience in lockdown. We're back to in-person, so we're hoping we can maintain that level. The last thing just important to note is phone appointments. Phone consultations specifically, kind of a mixed bag. We're seeing positive on phone consultations when it's like a follow-up with a doctor at a hospital appointment. Everything's going well, much easier to do it over the phone. Where people express concern is when it's a GP consultation. Very concerned that the doctor may be missing something because they can't see the patient in person. Moving on to the patient engagement report that we did. Now, this was a very small sample, and I'll touch on that at the end. We were looking at access and quality with minority groups across Ealing. A special thanks to the Action Youth Association, Horn of Africa Disability and Elders Association, and the Welsh Shore Community Hub for helping us organize kind of these town halls where we gathered our info. We were looking at predominantly integrated care. We looked at a cross-section of Asian and African backgrounds, and the sample size was predominantly women. The big issues that came about was the first, it's good to highlight, while they did have concerns about access to care and quality of care, it wasn't different to what we see across Ealing. It very much fit into the patterns of what we're seeing is concern around access and availability of information. What was interesting to talk to about was this breakdown in trust, the idea that if they couldn't access information or didn't believe that the information was available to them, they would believe that that kind of GP surgery wasn't catering to their needs. And that would mean that they're more likely to adopt misinformation. And we know how important that is when we looked at something like the vaccine rollout. The biggest issues in terms of kind of basic access were around tech, which is always going to present challenges, and language barriers. Because this survey was incredibly small, of around 54 people, HealthWatch Ealing is now doing a larger research project where we're looking to probably get as many as 12 times that number to see how prevalent these language barriers are, what are the issues surrounding them, and possible ways to kind of navigate it in a really easy way and direct way. One thing that kind of came up was this idea that just by putting a word like hello in multiple languages, all of a sudden means that the information available is available to them, and it draws attention and draws notice. But the sample size is quite small, so we're looking to expand on that to kind of fully grapple with the challenges around kind of discrimination, especially with language issues. Thank you very much for everyone's time. Hope it was informative. Thank you.
Great, thank you, Daniel. That was really helpful. A very good summary of the very large piece of work, both pieces, in fact. So thank you. And that second one particularly kind of, I think, resonates with the work the council's done in terms of the Race Equality Commission and other pieces. So will come in very useful as we move towards formulating the health and wellbeing strategy. Does anyone have any particular questions for Daniel? Neha.
Hi, so it's less of questions, but when I was going through the report, actually a lot of the recommendations coming from, especially that one, although it's a very small population size that was used for this, and I know you're planning to do a much larger piece of work. A lot of the work that we've been doing in the background resonates with some of the stuff that you've been saying. For example, we've just been through a procurement of recommissioning a new translation service. So there'll be a renewed focus on making sure that patients know about this service and GP practices know how to access it and use it. We've just kicked off today an audit of our PPG groups as well. And we're doing some work together around patient engagement. So, and there's all sorts of other stuff that we are doing as well in response to not only this report, but this resonates with a lot of the other reports that we've seen over the last few months. So really helpful. Thank you.
Thanks. Kerry.
Thank you. Just to echo what Neha was saying about the joint work around community engagement, I think it's also important to see that on the council website, we have a translation button that translates all the information on the council website into a range of community languages, which is really positive. But on the other hand, we know that there's a digital divide with a lot of people living in Ealing, and I think it's something that we work at with our voluntary sector groups to make the most of face-to-face engagement and other formats. So it's positive on the one hand that we've got that interpretation service on the website, but also keeping that strong focus on the direct engagement with people who use services and patients.
Great, thanks. I'm going to Excuse me. Thanks, Kerry. Anything else for Daniel? No, Daniel, any final words you wanted to add by way of summary?
No, thank you for giving me the opportunity to present. Pleasure.
Great, thank you. And I think Kehar and Nehar and Kerry, it's one of those days I'm dosed up on paracetamol as best I can. Have said it's a really helpful kind of piece of work, and it doesn't come as a surprise. I think many of the issues you've highlighted, but I think good to know that we are working on them together and separately as partners. So thank you very much. We've got 3 brief items now, just to verbal updates to note. And Anna, I don't know who's taking the plan for COVID lessons learned review.
Yeah, thank you, Chair. So that's mine. So for those I've not met, I'm Anna Bryden, Director of Public Health at the Council. So I think there's 3 from me and 1 from an NHS colleague. So if I just start with the COVID lessons learned. So this is something we've mentioned at previous meetings. We are, on behalf of the board, starting scoping work on a kind of lessons learned review from kind of how all of our health and wellbeing board partners responded to residents' needs during the height of the pandemic, and especially linking back to Basic Quality Commission findings about how we use that learning to carry on reducing health inequalities. So we're scoping that at the moment. We just this week appointed a new senior person in public health who will be starting in a few weeks. Who's going to start taking this forward, which is a really good resource to have here. Just 2 things to point in terms of overlaps with partners. So we are aware there's kind of other bits of lessons learnt reviews happening in other organisations, kind of naturally occurring, especially in some of our NHS partners. So we're working with those to reduce duplication and kind of develop kind of shared findings. Also, just for the board to be aware, the national inquiry is being scoped and started this year, especially NHS partners. I think more than other partners are being looped into that, and we are working with colleagues to see where that overlap is, and so we're reflecting the same key areas of learning. We'll just keep the board updated on that. Thanks, Chair.
Great, thank you. And then Better Care Fund update.
Thank you, Chair. This is an update in terms of the agreement for the sign-off of the Better Care Fund. It's been through the CCG authorisation processes and the formal council authorisation processes. The BCF is something that we do annually. It builds on the long successful history of joint integrated working that we have in Ealing between health and social care. Contributions from Ealing CCG have exceeded the minimum level of contribution to social care, and I think that's something that's worth noting for the board. Some planning and reporting requirements for the BCF return had been suspended during COVID, but we're moving back now into a position of the normal reporting frameworks. The submission confirms that Ealing has met all the national conditions, and that the focus of the BCF plan is, as in previous years, focused on reducing length of stay, improving proportion of people discharged home to their usual place of residence, avoidable admissions to hospital, reducing residential admissions, and effectiveness of reablement. This is an information piece, Chair, but it's just sharing it with the board.
Great, thank you. And I'm going to tempt fate, but having signed it off for submission, I've had no long string of queries coming back. So I think we are okay. So thank you, Kerry. Health and Wellbeing Strategy Update, which is probably the more important of the 4, although they are equally important. Anna?
Thank you, Chair. So again, this is something we'll keep as a running agenda item on the board for the next few months. So we're at the scoping stage of the strategy. So the strategy is a statutory responsibility for health and wellbeing boards. We haven't done one since 2016. Obviously delayed a little bit with COVID, but it's a really, really important opportunity for board members to work together, take something forward for the kind of next 5 years and really champion that joint working together. The strategy focus, I think, twofold. One is where we add value together and make that kind of structural and lasting difference together. So not just being a reflection of everything we're already doing, but actually where can we add value by working jointly across the local system. And then especially the particular focus on addressing inequalities. For this, I think that's come out very, very clearly from the work around the COVID pandemic, and the impact really shone a light on inequalities and inequalities in terms of access. So real focus for this strategy. Next step, really looking forward to meeting a lot of the board members next week. We've got our first strategy workshop, so please come if it's in your diaries. It'll be really a good session to start the discussions together and to begin identifying those priority areas for the strategy, and also to get involved in planning the engagement work. I think really central to developing this strategy is very meaningful resident community engagement. So we are exploring methods for that and working with a lot of our partners on that. We have got a very small steering group from a number of representatives from the Health and Wellbeing Board organisations. So that's just started the last few weeks. And one thing we have been doing in the background is a kind of stock take and a lessons learnt review from the previous strategy. So what worked well, what can we take forward this time? And really how have we progressed that strategy. So that's really good practice, I think, for us to do. And just a little bit on the timeline. So engagement, we already are listening to our residents, you know, from different consultations that have been out already in different engagement streams. And we will be taking more proactive work forward between essentially now and October. We'll then have a further workshop with board members after that engagement period. And we'll be essentially drafting paper in the autumn. And then we are going to take it through various sign-off processes. So for the council, that will be cabinet, and it's for our constituent organisations around this table to have a think whether they need to take anything through their boards, etc. And then just because of that timeline for sign-off, we'll be bringing final approval here on the 15th of March. So that feels like a long time away, but I think it's going to be a busy few months, and nothing to stop us taking forward some of the actions anyway before then. But that's where the final sign-off will be, and just really looking forward to kicking it off properly next week. Thanks, Chair.
Great, thanks, Anna. That's a really helpful update, and looking forward to seeing people in person. I know I have met some of you over the last kind of 18 months, but very briefly and in very specific circumstances. As I get jabs in my arm and so on. The last one, Anna, is the Joint Strategic Needs Assessment Annual Update. Yeah, thank you, Chair. So a paper has been attached with the board paper, so hopefully people will have a chance to read that. Doing the Joint Strategic Needs Assessment, again, is another statutory responsibility of Health and Wellbeing Boards, and it was just a proposal that we bring an annual update here, just as a very, very short paper. So what have we done in the last year, and what are the priorities proposed for the year going forward? We refresh those topics and chapters on an annual basis and keep a kind of background population characteristics JSNA on the website, keep that updated. We've got a JSNA steering group with a lot of members from here and constituent organisations. So just looking back over the last year or so, because of the pandemic, obviously it's been a little bit more light touch than we would have liked, but we have still managed to produce really good chapters: sexual health, children's healthy weight, and the more comprehensive COVID impact assessment that's now being published as our public health report. We've carried out a prioritisation exercise with steering group members this year. So over the next 12 months, we're aiming to produce chapters around autism, learning disabilities, mental health and substance misuse. We're also going to create more updated profiles of our 7 Ealing towns and link those across with the profiles that are being created by the NHS in terms of primary care networks. And also this is very nerdy, but we are actually getting census results finally in the next few months. It only happens every 10 years. So that's a really, really big opportunity for us to see how things have changed in Ealing and how they're going to change in the future. I think especially in terms of ethnicity. I think there's, expected to be quite big shifts in London, Brexit, everything else you can think of. So that'll be a really good chance, and especially where we're talking about taking forward some of the Race Equality Commission recommendations, so doing much more deep dives into what's our population look like in a lot more granular detail,
and how are the outcomes different across different groups of people. That will be a really big marker for us in terms of being able to take that work forward. And then just very finally, the terms of reference for this and a steering group are included in that report, including the membership. We have just refreshed that very recently. We're not precious about it. So if anybody feels there are gaps there in terms of health and wellbeing board members or others, please do get in touch with me, and that would be great to have people on there. Thank you.
Thanks, Anna. Before we formally note those 4 updates, are there any urgent questions on any of those? No, so I think we can formally note them. We have heard them. So I don't think we need to, unless people want to nod at me, I think we can move on to the London North West NHS Trust update. And I don't know, Joe, James, who is leading?
Hi, it's me. Hi, Joanna Paul. I'm Director of Operations at London North West. Thank you very much, Councillor. If I can share my screen, and I'll just go through the slides that I think are in your pack. Have those come up?
Yeah, perfect.
Brilliant. Okay.
You could, if you could take them on the presentation mode so we can see them a bit bigger. So some of them are quite dense.
Okay. Does that come through on presentation mode? Great. Okay. So just to go through, we'll just do a quick update around COVID and impact on where we're at in terms of COVID, talk a bit about our recovery plans. The CQC unannounced inspection report from May, our investments and work we're doing, and joined as well by, to introduce James Biggin-Laming, sorry James, who will also take us through our way forward strategy refresh. James, do you want to introduce yourself?
Too used to Microsoft Teams, sorry. Hi, I'm James Biggin-Laming. I'm the Transformation Director at London North West and co-leading our work on our strategy, which I'll talk about at the end of the presentation. Okay, so just first and foremost, then transition to COVID and living with COVID. So we have our slide effectively showing the volume and the level of cases within the organisation. As of today, we have 6 patients in Ealing who have got COVID. Many of these are coming in actually with incidental COVID as opposed to being admitted because of COVID. And overall in the trust, we've got 38 patients, so a few more at Northwick Park, but given size, you would expect that. On the 20th of May, NHS stepped us down in terms of our response from 4 to 3, given the level of impact and the level of COVID in the community, which just means that the impact is far less within health. Our admissions, as I've said, are falling. And in fact, today we've gone mask free in the hospital, other than areas where we have COVID, and we've taken off all of the sort of issuing of masks and things at the door, which we'd had really for the last 2 years. So it's been a big step. Less than 1%, it's significantly less than that at the moment coming in with COVID, and we've been simplified our infection control, and we have visiting changes. So that's changed in the last week. So we were in masks where patients are being visited and they're in an area where they're vulnerable or they have got COVID, we are still using masks. So we've seen a significant move for the positive. In terms of recovery, we're working pretty much all of our work around recovery. We talked about waiting times earlier, but we've got some ambitious targets around increasing our, as you would expect, our activity to bring the waiting times and the backlog down that accumulated during the period of COVID. For our elective position, we are now running at around 91.7% of our May position, outpatients at 89%, and we're on a trajectory of every month where we're increasing that level. Outpatients, we are particularly follow-ups looking to reduce those by doing virtual and other clinics down to 75%, the national target, and we're working to reduce that. And then we've got diagnostics, as you can see, pretty much back to where we were pre-COVID and increasing our levels. We're on plan to reduce our waits down to 0 for patients waiting 78 weeks down by March, and the 104 again for June down to 0. So significant reductions being achieved against our plans. Simon, you're present. You were going to want to have a talk through the CQC inspection report. So I'll hand this over to you.
Hi, Joe. Apologies, council members for joining late, but Joe clearly doing a good job in my absence. But yes, just wanted to share with you the findings from the CQC inspection. We received the report in May 22. The inspection itself took place from the 9th to 11th February, where they undertook unannounced visits to Northwick Park and Ealing hospitals, and particularly focused on medical care and surgical services as part of the inspection. And this was followed up by a well-led inspection on the 8th and 9th of March. The overall rating remains the same, which requires improvement. But if you were to read the report, I think what we're extremely pleased with is the narrative. There have been, I'll come on to some of the specific movements and improvements at Ealing, but the narrative is very different, I think, to previous reports. It does talk about a culture of change. It does talk about improvements being made. It does talk about things being taken seriously, and in particular for Ealing, it talked very much about how friendly the hospital was. It felt like a sort of fat family hospital, and the narrative in the comments were really strong and positive. The two key areas they visited in terms of medical care and surgery. So if you take the first line there you can see on medical, the arrows, which have been highlighted now, indicate, so the first one on safe went from inadequate to requires improvement. So that was a step up. The medical care went the effective went from requires improvement to good, and the caring went to requires improvement to good. So those are clearly helpful. The responsiveness and the well-led stayed at requires improvement, which means that the overall score for medical care stays at requires improvement. So the responsiveness related to some issues around waiting and access for diagnostics, and then therefore that also then feeds into the well-led rating as well. For surgery, you can see the score again has improved from safety has gone from requires improvement to good. The effective has gone from requires improvement to good. The caring has stayed at good. The responsive is stayed at requires improvement. The well-led has gone up to good. So the overall rating in terms of surgery has therefore gone up to good. So although the overall score stayed the same, it requires improvement. There are significant movements within the report that are described, and as I said, the narrative is really positive. So as a leadership team, we're pleased with the movement that has been demonstrated, and we recognise that they've come back on the back of recent visits in a fairly short period of time. And I think we recognise that what we've got to demonstrate is that sustained improvement over a period of time before they're going to move us from requires improvement to good in totality. But, you know, at this point in time, we're pleased with the progress that's been made across the organisation and the feedback that we've had from the CQC. So should we pause at that point? You haven't done the service developments at Ealing, Joe, have you? Do you want to finish the service developments at Ealing, and then we'll pause at that point before we come to James and the strategy development, and then if there's any comments on the feedback in terms of the update from the hospital as is now and the improvements, and then we can report about the overall trust strategy going forward. So Joe, do you want to do the next slide?
Sure. Okay, so in terms of service developments, trauma, we restarted. When we went into COVID, we had to take out and closed or transferred surgery across to Norfolk Park. That included trauma because of the requirements around anaesthetic cover and maintaining safety of the service at Ealing for patients needing critical care. It was a lot of work, but I'm really pleased to say that we'd already restarted our emergency surgery service back in December, and on the 28th of March, we started trauma. We have seen 83 patients in the first month, and actually we look like we're on track for significant growth actually in supporting trauma here at Ealing. Refurbishment of endoscopy has been completed, and that allows us to maintain privacy and dignity for patients, and significant improvements in the setup in endoscopy. MRI, we're in the process of just completing, and that will be in place by the end of June. And we're in the process of procuring the new cardiac cath lab, which commenced in April and will be completed and online for September. We are in the process of working with the national team around the development of the Community Diagnostic Centre here at Ealing for establishment in 23-24. And the other major agenda and transformation work we're doing is around our progression towards implementing our new information system, Cerner programme, as part of the North West London wider acute programme across Imperial Church West. We're going live with Hillingdon as first across London North West, and then Hillingdon shortly after from August 23. So those are the, I think, the major items that we're working on currently.
Yeah, and it's just worth saying that they do represent considerable capital investment by the trust on the site. I think in terms of endoscopy, that will help us in terms of catching up with the diagnostics and the recovery, as will the MRI completion on replacement and the cath lab. So they will all help in terms of the increasing volume of treatment taking place on the Ealing site.
Yeah.
So there's a question from Judith: what will the community diagnostics be diagnosing? So there's a whole range of things going into that. Not least is a permanent replacement for the MRIs into the main body of the hospital. And James, did you want to add to that, because you've been involved in the diagnostics side of things?
So there's a number of these you might have seen announced in the press across the country. It includes diagnostics like MRI, CT scanners, X-ray. We're looking at audiology and other areas as well. Central to a lot of the investment behind this is about cancer diagnostics and the UK's relative performance in early diagnostics. So it will expand opportunities in the community for care like that.
Yeah, there'll be a DEXA scanner and sort of also respiratory and cardiology, community cardiology clinics. So as you say, there's a wide range of services incorporated. That's probably a 2-year program in terms of delivering that.
Great, thank you. So are there any other questions on the recovery points, the CQC or service development? I think we should note with positive, with a positive tone, the CQC inspection. As you say, it still requires improvement. I think we need to acknowledge that, but good progress. And thank you for that update. And particularly on the surgery, some really positive news. So congratulations to everyone who's been working. I think the question then is, how confident are you that the actions you've got in place will deliver improvement where we've not been improving, so that where we've stayed the same?
So I think we're extremely confident. I think in terms of that, I think in the context of the the things that certainly in terms of medicine, when they were concerned about medicine safety and record keeping and that kind of stuff last time round, they absolutely recognise that it's been a sea change in that, and also sea change into, I think, into the engagement of the staff and the positivity of the staff across the organisation, and you can see the improvements in surgery as well. So running alongside this is you take something like our staff survey. So this year we did a massive improvement in our staff survey with a 61% response rate, much more positive feedback from our staff in terms of engagement with the leadership team and clarity around role, responsibilities, etc. So I think there are lots of positives in the organisation internally, but also I think there's lots of positives in terms of the working relationships that we've got across the trust and out with the trust, both locally here in Ealing, but we also see that in Brent and Harrow as well. So all three of those sort of strands, I think, are taking us in the right direction to be an organisation that is responding in the right way, addressing the difficulties it's got, investing in the right way, and certainly trying to support and engage with its staff in a very different way to what we've done previously. And to be honest, things like teams have made a difference. When we have our sort of team briefs, we have 300 plus staff on those now. You know, pre-COVID, we'd be lucky sometimes to get 30, 40 people in a room. So. And there's many more of those types of opportunities for engagement that I think will be here to stay. So I think we are confident that those things will improve going forward. And things like the Cerner, one of our Achilles heels is access to an integrated clinical record. So that's going to make a massive difference in terms of efficiency for our staff, accuracy, sharing medical records, organising our services and delivering those. And it'll be the same platform as the four other acute trusts in North West London. So that will also help us with all four acute trusts in terms of engaging with primary care and other services as well. So all of those things, I think, are really positive for services going forward.
Great, thank you. Judith has her hand up.
Yeah, thank you, Simon and Joe. I agree, really helpful to see such good progress, and great that the staff feedback is strong, given that we've seen elsewhere in the NHS that it's not, and nationally it's not been so strong. So that's really positive. Just reflecting on the inspection regime, because Ealing Hospital doesn't deliver either community or inpatient children and maternity services now, Simon, in future it's probably worth also bringing in that connection to the Health and Wellbeing Board in children's services that are delivered through other sites. Not necessarily for now, I wouldn't expect you to cover that now, but perhaps for future. Thank you.
Yeah, we could do that. Yeah.
Great, thank you. Anything else for Simon and Joe before we move on to the future? No, so I think then James on the strategy.
Yep.
Thank you. Just 3 points to cover on the next slide to bring out. So the first around why the strategy and how we hope this will support some of the discussions. We've already touched on the health and wellbeing strategy. Secondly, about the approach we're taking it, and third, around the engagement that we're doing as part of it and ways for people to contribute. Firstly, on why we're developing our strategy. As with many others, COVID has been a sea change in how we think about things. It has been a number of years since we last did a clinical strategy as an organisation and what that means. And with all of the changes, both in our pathways, our services, how we're working with partners across the system, what we've learned and been able to do, this is an ideal opportunity to look at what do we do differently, how do we have our way forward over the coming years, and recognising the need to work with so many different partners as well, being able to really engage with that as an organisation, having a clear sense of our strengths, our opportunities to contribute, and our purpose as part of that, or the roles we'd like to play. So with that, you've got our sort of plan on the page for our strategy work that's ongoing at the moment. We started it in April with a team of people with seconded sort of project team with our staff. We wanted it to be owned and led by our staff and with our organisation, but working with lots of other partners as well. And that's going to be going to run to sort of make recommendations by the end of September. 3 important elements. First, to give us that sense of direction around our case for change, what that vision and how we would go and focus and deliver some of that in the future. The engagement, I'll say more about that in a moment, about ways to get involved, but also using this as an opportunity to further build capability in the organisation. We talked about some of the improvements we've already seen and CQC have recognised, and that's with the project team. We've been fortunate to have guest speakers come and tell us what makes good strategy and helping involve our different staff as part of that. On the engagement, we have been working with our staff, we have been working with patients, we've been working with partners, and we've been doing that in a number of different ways. One of the ways I really wanted to encourage, and if you could share, fill in yourself, but also share through your networks, is our patient survey we have live at the moment. We've had over 100 responses so far. That was the update today. It's been open for about a week. It's very easy to find. If you go to our website, lnwh.nhs.uk, it's on the front page at the moment, or if you want to go directly to it, lnwh.nhs.uk/way forward survey. We've translated it into the most common languages in our patch as well, as Gujarati, Polish, Romanian, and as one other, so I have to go and double check. We wanted to make sure it was inclusive as part of that, to give everyone for everyone. So please do share with that. We've been in touch and we've sort of had people involved in sort of interviews and others for some of that input. We've invited a number of partners to 3 events we're running as part of the work, called our stakeholder forums. That involves patients, it involves staffers, but also representatives from partners. The first of those is on the 6th of July. It's going to be at Kenton Hall in Harrow. The second is going to be on the 19th of August. We're sourcing a venue in Ealing, and the third in September, which will be at a venue in Brent. And with those, it's a chance for us to share our work as we go along, and we want input. The first session really focused on our case for change, how others see, this is the analysis information we've collected and people's input on that and what that means. The second, some of the choices we're making. The third, about how we make sure we go and deliver on some of this action. And as part of that, we want to get a clear sense of, here is our site strategy, the services for Ealing Hospital and what that will mean and how we work, and use that as a base to support other partners, use some of the investment potential like the Community Diagnostics Centre to really enhance the model of care and what it can offer with the community, as well as how our other acute services working between our sites and our partners in North West London will help improve care over to the future. The last thing to say on the engagement, we are doing these events to invite people to come to us, but we'd be delighted to come and talk to people just as we're doing today. So if there is input, if you're having sessions or links with community groups, part of our project team, whether me, one of the medical co-leads, we have some co-leads from representing medicine, nursing and allied health, or some of the other project team to come and even just come for a few minutes to be able to hear people talk about some of what we're doing, have the opportunity for that input. Would welcome people getting in touch with us and letting us know, so we can hear from people, as well as sharing what we're doing and inviting people to some of our events.
Great, thank you. Simon, anything to add?
No, I think James has said it all, really. I think, it's an indication that we're doing things differently. We're not just doing this in isolation internally. We haven't got an outside consultancy firm to come and write a strategy for us and say, oh, here it is. We are developing it internally. We are involving our staff, but we are definitely very keen to involve our external stakeholders and partners in terms of helping us do this and shape it. So whilst we recognise that we run 3 acute hospital sites, we absolutely recognise our patients come from the community, are supported by community services, and we've got a role to play outside of the hospital. And part of the broader piece of work around our strategy is around it as an anchor organisation and what we could do in that space. So I won't take up time with that here, but that is something, Judith, Kerry, that I'd welcome further conversations with you in terms of, as a borough, how do you support us and how do we support you with those ambitions around the inequalities agenda, recruiting people locally into the services, but also using our purchasing power for social value, etc. So happy to take any questions on the strategy development as described.
Great, thanks, Simon. That point, I think, just feeds nicely into the workshop we'll be doing next week in terms of anchor organisations and how we all can work together to deliver the outcomes that we've kind of agreed for the health and wellbeing strategy.
Are we invited to that? Are we included?
I'm going to say you should be, looking at Anna's name on screen, but if not, I'm sure we can make sure that you're represented.
Yeah, but if we haven't got the invite yet, if you get it to us, I'll make sure someone's there. And if I've missed something, please remind me.
Anna is nodding, so we will make sure someone is in the room. Judith.
Yeah, thank you. I thought that was really helpful again, and good to have that communication to us at an early stage so we can work together on it. I was thinking about the Race Equality Commission also, and the requirement on governance and workforce and also access, and just the extent to which we're building that into the strategy. It sounds from that conversation like that's very much in your minds, but it'd be interesting to flesh that out in more detail at some point. Thank you.
And then Kerry.
Thank you. Yeah, really helpful presentation. Thank you, colleagues. My question was really about reporting back to the Health and Wellbeing Board as you progress the strategy, ensuring that we get the consultation documentation shared at the earliest possible date so we can really contribute to the process. And I think, James, you said you were going to share that with me.
Yes, so I'm too used to using Microsoft Teams. Apologies, Chair, for not putting my hand up. I don't know where to do it. Yes, so our first event is on the 6th of July. The format we're planning is to have we've been collecting all sorts of analysis. So Judith, you just talked about some of the race equality and some of the other expectations on the organisation. So that Case for Change gathers all of that together. We'll share that in advance with people participating, and it will be shareable within the networks. Be delighted to come back and share sort of highlights from that and almost how we're coming through. There is lots and lots of material. The team have been working really hard. So some of the synthesis and summary for people to input. And then as we go on and get towards the end, further input on here's what we're seeing, here's what we're thinking to contribute to that. And then for ourselves to be able to contribute to the health and wellbeing strategy and other partner strategies into the future.
Thanks. So Judith is asking about clarifying the August date, given often summer holidays not often very good for engaging because people are off looking after children.
No, it's the 19th. So Friday, the 19th of August. We didn't want it too close to the bank holiday because I know lots of people do their time there. We are designing all the events as hybrid, not to say you want to join from the beach if you've gone somewhere for your holidays, but we're looking for ways to make sure it's inclusive so people could join remotely as well to balance as much as possible. And just like the first event, we'll share material in advance so people can contribute and input outside of the meeting as well.
And James, I think it's worth saying that they don't have to necessarily, we'll have a focus on Ealing when it's in Ealing, but if people wanted to join one of the other ones in July or September, you could do that as well.
Yeah, but it's not 3 events that are the same thing. It's going to be progressing as we go through the strategy. I would, if people can, we had an event earlier today in Brent, and it was a great energy in the room, having lots of people there, and I think you'll get, there's more for if you can make the journey to come and join in person, but there'll be opportunities to contribute as well remotely.
Great, thank you. And given what Daniel was saying earlier about community languages, really helpful to have the survey available in other languages. So that's really something that I think we probably appreciate, and thank you for kind of making sure you've gone to that effort. I think how you present this will be really important given some of the history in Ealing, should we say, and I think, Simon, the comments you've made about the investment you've already made and are planning to make on the site are really reassuring at this stage, shall we say.
Good.
Thank you for making sure those have come across, and we look forward to getting involved and making sure it is disseminated as widely as possible. Are there any other questions then on the strategy process, or if not, we can move on to another very meaty item, and one that I think we've mentioned a few times at the board, and Neha, I think, will lead on a presentation on the ICP/ICS update. And I think since we last met, we've changed from a ICP to a an ICP to a BBP. So I think the agenda item is out of date, but we will take it anyway. So Neha, over to you.
Thank you. I will explain some of these acronyms as we go as well. So I'm just going to share my screen and put the slides up. Just bear with me. Right, I'm hoping you can see the slides. Yep.
Yeah, if you could just pop them on presentation mode. Having flicked through earlier, there's some very small text. So the bigger the better. Thanks.
Hope you can see that. Right. So this is there's a hybrid of presentations in here. One is the update from our local borough-based partnership working, which used to be called ICP, Integrated Care Partnership. And due to some of the national language being used for some of the wider system acronyms that they're using for various groups, which I'll explain in a minute, we've had to change that to borough-based partnerships. And I think it makes sense, actually. So just as a reminder, as Ealing has been working on integrating care and collaborating between partners for many years now, and these are some of the strong foundations that we've built over the years, even without this new move to working more of as a collaborative, some of our successes. And as another reminder, this is our delivery structure, as well as all of the partners involved in our local borough-based partnership. So they're in the pack if anybody wants to look at them in detail. So through 21-22, we've been working, obviously we've had the pandemic that we've been dealing with as partners, and all of us have had a very significant role to play. But there have obviously been some other challenges and difficulties, partly due to COVID, but partly just capacity to move things on. But some of them more wider ranging, such as the lack of estates within the local area, the workforce and that we have, and being able to recruit staff and retain them in roles within Ealing, but also just the sheer volume of capacity needed to deal with the backlogs as a result of COVID and other things. Some fantastic stuff has come out of COVID in the partnership and collaborating in very different ways and learning from that. And it's really important that we learn from that and build on that as a partnership going forward. But some of the challenges that have really come to light are around the inequalities that some of our population have faced. For the vaccination program, it became quite acute and visibly acute, but this has been historic. There has been inequalities in service provision, but also people coming forward and accessing certain services as well. So there's a lot of work to do, and we recognise all of that as a partnership. So as a group, we've been looking at our priorities and objectives for the year ahead. And these are at very high level, some of the areas that we're really focusing in on. And what's really interesting is the Integrated Care Board and the Health and Care Act that received royal assent in April 22 clearly pushes us as a local borough-based partnership to work in more integrated and collaborative ways. And our integrated network teams is going to really help with a strong foundation for the future in that as well. But also some of our priority areas that we know we need to focus on, such as population health, inequalities and inclusion work that we need to do. And you heard Anna talking about some of that today. The race equality, very much flows right the way through all of this. Our support for some of our more vulnerable and patients in the community and people in the community, people with learning disabilities, those with complex needs, those the older people population, our children and younger people as well. A really big focus on improving care and doing everything we can proactively about giving them a good start and a good journey through into adulthood. But in all of the enabling resources that we're going to need to put in place. So we need to have really strong estates plans in place. We need to have really good cooperative working around workforce. And we've just talked about anchor institutions, for example, digital and BI. We have the strong Section 75 and Better Care Fund that we've already discussed that we need to build on, and the but also we need to do much more on community engagement. And we've just recently recruited to our new clinical leadership structure, and that will add some value into some of the conversations and some of these pathways. But I wanted to focus a little bit on the move to the Integrated Care Board and what does that mean for us as a partnership. So as you all know, the Health and Care Act received royal assent in April 22. And the main purpose of the Act is to establish a legislative framework that supports collaboration and partnership working to integrate services for patients. And it's recognised that working as borough-based and smaller population groups, you can have a real positive impact on outcomes and health outcomes in particular, but also looking at the wider determinants of health as well. So as of 30th of June, at the end of 30th of June, CCGs will be disestablished under the Act, and their functions, our functions, will largely be subsumed into the Integrated Care Board, and I'll explain the two parts of the system that are being established on the 1st of July in a moment. So we'll have our last governing body this month, and in July we'll start as an Integrated Care Board, and all of our staff at a local CCG level will transfer into the new North West London Integrated Care Board, which becomes a statutory organisation. This is just a bit of a description about the function of the Integrated Care Board, as I was describing before, and it's really important that we work closely as a partnership across at a local level, but also at a North West London wide level. And this is a diagram from the King's Fund, which tries to describe all the various components of the integrated care system as of July now. This was old because it got delayed slightly. And there are two statutory parts of this integrated care system at a North West London level, which we've formed. There's the Integrated Care Board, which has a function of the commissioning and oversight of a lot of the services that currently the CCGs undertakes, but working really closely with all of the partners. And all of our local CCG team will be transferring into the Integrated Care Board. That will be the statutory organisation. And then the Integrated Care Partnership, which is a partnership of a number of organisations, including our local authority, public health, looking at social care needs, and overseeing the patient and public engagement, and making sure that they are leading the strategy and influencing the strategy of the Integrated Care Board. And at the bottom half of this diagram, you've got a bit of a description of the various system structures. So you've got provider collaboratives, that's another part of the system being set up. So all of our providers, our acute providers, are working together, for example, to create their provider collaborative. Mental health are working as a collaborative, community as another collaborative, for example. Plus you've got health and wellbeing boards, which is what we're at now, our place-based partnerships, which is what I was just describing as borough-based partnerships for Ealing. And then we have at a more local neighbourhood level, primary care networks covering populations between 30 to 50,000, We've also been advised that come April 23, depending on assurance processes, community pharmacy, dentistry and opticians will also be coming down to the responsibility of being commissioned by the Integrated Care Board. That will be April 23, though, not yet. So this slide just describes the Integrated Care Partnership and the board and their functions and the chairs. And then this slide here is just the NHS England key objectives set out, the 4 key objectives set out of what we're trying to do by setting out this Integrated Care Board. At a North West London level, we've agreed these 9 core programmes to deliver our objectives and vision, which are the 4 delivery programmes around improving health and reducing inequalities in health, local care, including primary care, that includes community and other services, mental health and care for people with learning disabilities and autism, and then acute care. And just like our local borough-based partnership, there are enabler streams as well, which is workforce, research and innovation, digital, data and finance and estates. In addition, there are a number of clinical networks focused on specific groups as described at, just below that. And as you will all know, some of our health challenges and inequalities and life expectancy differences across North West London are just described here as some of them. They're not all of them. And to be effective, it's really important that we have a co-production approach to working with our local residents, and there's a lot of work happening about how to ensure that the voice of the local residents is heard. Staffing, we need to work and be an employer of choice and an exemplar for staff wellbeing. We've already touched on that today in this meeting already. We have to work as one team across health and care. So there is a lot of work to do to bring all of us working in possibly slightly different collaborative ways than we have historically, where it was a commissioner and provider split. And definitely adopting the innovation that we have, and we have some fantastic stuff that we've been doing as a system already, such as our whole systems integrated care dashboard, where we have data which is unique across the country. And so far, so this is where we are getting to. We have we are recruiting to the executive director posts across North West London, and as you'll know, the chief designate is Rob Hurd, and some of the other posts have been appointed to, and there will be communications out as and when they are appointed. We have to complete a readiness to operate statement submission by the first, by it's mid-June, I think it is, to be ready for 1st of July. And it's a very long checklist that we need to go through around due diligence about closing down the CCG and starting the new organisation. And then this just describes some of the timelines to establish the Integrated Care Board. So and the last few slides, which I won't go through in any detail, but just are in the pack, give you a bit of an update around the various streams that we've been working on as a borough-based partnership over the last few months. I'll stop there and happy to take any questions, and I'm sure my colleagues would as well.
Great, thanks Neha. Making a rather complex system look very simple and sound very simple, so thank you for that. There was a question on the chat that I think has been answered by Vijay about how the borough-based partnership gets a voice at the ICB, which is that there'll be representation on the ICB. Is it worth just exploring just for a second what that representation is and where it comes from? Because obviously there might be there are different kinds of representation, and if it's an acute trust versus other partners in the BBP. So do we know who it is and what it looks like?
Yeah, so Josh, so first of all, I think just so that everyone's aware, in terms of this transition from the single CCG to the ICB, I think what's important that we need to ensure that we maintain stability during this transition period. So in effect, you know, it is going to be a lift and shift in terms of how how locally we organise ourselves in terms of our local governance, and so we maintain that stability as we go through that iterative process in terms of the new ways of how we'll be working at a borough level. And I think it will become more and clear and apparent once we have a better understanding in terms of what's being delegated down to a borough level. And so our local borough place partnership will have much better clarity going forward in terms of what is delegated to us, and then the decision making that underpins that delegation, and that will happen in time as the ICB starts to bed in. But certainly nothing's really going to change on the 1st of July from that perspective. With respect to the ICB representation, so on the ICB, there will each of the acute trusts, their chief executive officer will be represented on there from the acute trusts. Also included in that would be the community providers and also one of the mental health providers as well. In terms of the borough place partnership, it has been agreed that each of the 8 borough place partnerships will have representation, and it's really to be partly determined by locally who would that be. So primarily it will either be the director of our borough place partnership, or it could be the medical director of the borough. That is where the understanding and approach is more likely to be from that perspective. And so that's going to be really important for certainly for Ealing. And there will be other representation in particularly in view of primary care, so there will be a separate primary care representation as well, and there will be a nomination and then a selection process for that, and there will be one of the CEOs from local authority, and each of the 8 local authorities will decide which CEO from local authority will represent all 8. So that is the approach that's going to be undertaken.
Great, thanks. Joe from West London then. Is
Yeah,
that a question, or is there more?
No, it does answer my question, and thank you. And I sort of knew the answer, but I wanted to highlight it. I think on one hand, I'm really excited about the new structure. I think my concern is how we make sure that all the communication links work and information flows. As we have provider collaboratives coming in, and then I would say surely it's one acute trust representative, the same way it's going to be one mental health. And I suppose that's my concern is always the slight push to an acute medical model of focus of care, and how we make sure primary care, community care, mental health, etc., it gets a good airing. So I suppose it's just, I haven't got any answers at the moment, and I absolutely take Vijay's point, it's going to evolve. But I just think we need to be very mindful. Anyone who goes to those types of meetings needs to be making sure there's a good communication, because otherwise I think things could fall between the gaps.
Yeah, absolutely. Yeah.
Thanks. Neha.
Yeah, absolutely. I'd echo what Joe's just described, because inevitably when you start a new set of governance and systems and processes, you have to sort of put it in place and then make sure that things are flowing, and where it's not, actively challenge that and find a way to find those solutions. And we found that when we moved from 8 CCGs to 1 Northwest London CCG in April last year. So there is definitely that risk, and that feedback loop of what is happening at the ICB level, but also the ICP, the partnership as well, back into Ealing. And our influence into the ICB about what is important for our population, which is why our borough-based partnership working is so critical, and the role of the Health and Wellbeing Board in that as well, and making sure that our voice is very clear, defined and heard.
Yeah.
Great, thank you. And Kerry.
And just to say, Josh, I think it's really positive for us to reflect on the work that's happened over the last 2 years within Ealing Borough and with partners from the council and the NHS. And I saw a presentation that the West London Trust had done on the development of a designated care setting in Ealing, and I think that took all partners, came around the table, and we worked very closely, and we were one of the first in the country, I believe, to set that up. So I think this is really building on that excellent relationships that exist within the borough.
Great, thank you. Are there any other questions then for Nehal, Vijay, on the ICS, ICB, BBP item? No. Well, it's a conversation we'll keep returning to, I'm sure. And I know the conversations will be the same partners in different rooms with different hats, but important, I think, as everyone agrees, to keep those conversations going. As Joe says, they're really important just to make sure those conversations happen between the kind of key meetings as well, so that voices don't get lost. Judith.
Yeah, thank you. And I agree, it's excellent joint working, really successful. One of the things, had we had local residents here, they would have asked us about the public facing nature of our BBP, so that just to reassure for the purposes of the minutes that that's something we're actively thinking about and working out how we can engage better with the public. Thank you.
Thanks, really important point. Okay, so we'll move on. I did see Ilyas earlier on the local plan health study, but Anna, are you going to take this? I can see Ilyas now. Sorry. So local plan health study. Do you want to? I don't know which of you is introducing, but do you want to explain what it is?
Thank you, Chair. I'll just introduce very quickly and hand over. So we've got Ilyas tonight. Thanks for joining us, Ilyas. He's our principal planner from the council planning team. And we've also got Mandy in there in the background. He's one of our public health consultants who works across with a lot of our place colleagues. So this is really just for Ilyas and Mandy to update us around the local plan. Ilyas will explain it a lot clearer than I can, but it's essentially our kind of key council policy document for the next few years in terms of how we take forward planning decisions, and health and wellbeing is a really big consideration in that, and it's great that we've been doing this joint working, and we've also had external resources in to support us with this. So just really excited to bring that here today, and I'll hand over to Ilyas. Thank you.
Thank you very much. Good evening, everyone. I will try to share my screen with you. Please let me know if you can see it okay.
We can. You may just wish to switch the screens round on display settings, I think, so that we're seeing your view rather than our view at the moment.
Right, okay. I'm not sure how to do that.
If you want to slideshow, Ilyas, just that top middle button, that should take you to slideshow.
Slideshow.
Yeah.
Yep.
Yeah, that's it.
Great. So good evening, everyone. My name is Ilyas Trivilas. I'm a principal planning officer in the strategic planning team, and I will give you a short presentation about the ongoing local plan health study. I will start with explaining why this study is important, and it will start with the national policy context. This is set by the National Planning Policy Framework, which states that planning policies and decisions should aim to achieve healthy, inclusive, and safe places. This includes enabling and supporting healthy lifestyles, for example, through the provision of safe and accessible green infrastructure, sports facilities, local shops, access to healthier food, allotments, and layouts that encourage walking and cycling. At the regional level, the policy context is provided by the London Plan, which the latest version was published in 2021 by the Mayor of London. The London Plan states that the mental and physical health of Londoners is to a large extent determined by the environment in which we live. Factors such as transport, housing, education, income, working conditions, unemployment, air quality, green space, climate change, and social and community networks can have a greater influence on health than healthcare provision or genetics. And many of these determinants of health can be shaped by the planning system, and local authorities are accordingly responsible for planning and public health. At the local context, now, Ealing Council's 3 top priorities include creating good jobs, tackling the climate crisis, and fighting inequality. And health is a cross-cutting theme that is directly influenced by each of these 3 priorities. And why are we doing this study now? Well, given the strategic context, Ealing Council, working closely with our NHS partners, including the North West London Clinical Commission Group and the Healthy Urban Development Unit, we have commissioned consultants Arup to undertake a comprehensive health study, which will inform Ealing's new local plan. Ealing's new local plan is currently being prepared, and it will set out the vision and strategic framework for the future development of Ealing over the next 15 years. It will include policies that support opportunities for inclusive growth, strategies for mitigating and adapting to climate change, and will also focus on promoting a pattern of development that enables people to lead healthier and more active lives. The preparation of Ealing's new local plan and the Council's ambition to fully integrate health into its local plan policies makes this the perfect time for us to undertake this work. And I would like to add that Arup, who are working on this study, are helping us with many other pieces of evidence that will support the preparation of the new local plan, so they have a very good understanding of Ealing and the local context. So the determinants of health, there are a wide range of factors that influence the health and the well-being of people. And this starts from the global ecosystem, which includes climate stability, biodiversity, the natural environment, the built environment, the local economy, the community, the lifestyle, as well as the demographics of the people themselves. And what is really interesting is that all these factors could make up to 80% of the contribution towards the health and well-being of people, with clinical care, which includes access to care and quality of care, only accounting for as little as 20%. So this shows just how diverse are the factors that can affect the health and well-being of people. And that's where the local plan is very important in trying to shape how we address these factors and how we can improve health and well-being outcomes. The study is still ongoing, but some of the emerging findings are that these are the key priorities for improvement in Ealing. Poor air quality in the boroughs across all neighborhood areas, particularly in the east. High housing needed demand, particularly for affordable and accessible housing. Relatively high levels of fuel poverty and hopelessness. And we all appreciate that with fuel prices currently not record prices, fuel poverty is likely to only get worse. Relatively low levels of active travel and walking and cycling for leisure. And again, different parts of the borough perform differently in terms of these health determinants. High levels of income deprivation among older people, those aged 65 plus, as well as children, particularly in the east, for example, parts of Acton, and west, parts of Southall and Northolt. High proportion of people claiming out of work benefits and long-term claimants of job seekers allowance, and uneven distribution of parks and green spaces. Ealing is one of the greener boroughs in London. However, much of the green open spaces we have tend to be concentrated towards the western part of the borough, which, again, if you move closer to central London, for example, Acton, you will find fewer and smaller green open spaces. Southall, Acton, and Northolt have been identified as the neighborhood areas with the lowest scores across the various health determinants. In particular, Southall faces particular challenges across a wide range of health determinants, climate resilience, education, employment skills, health facilities, infrastructure, housing, living environment, nutrition, open space and nature, health outcomes and risk factors. Acton faces particular challenges in the areas of climate resilience, housing, open space and nature, while Northolt faces particular challenges in the areas of climate resilience, crime and community safety, education, employment and skills. In terms of health facilities and infrastructure, almost 98.4% of households in Ealing are within a 15-minute journey time to a GP, either by walking or by public transport, which compares very favorably to the national average of 70.7%. The vast majority of general practitioner practices in Ealing, which were inspected by the Care Quality Commission, were rated as good or better, 72 out of the 74 inspected, with only 2 GP practices being assessed as requiring improvement. Similarly, the majority of patient experiences of GP practices in Ealing are also rated good. However, GP capacity assessment indicated that the majority of GP practices in Ealing, approximately 70%, are over capacity. This means that these practices have more patients per one full-time equivalent than the national benchmark, which is 1,800 patients per one full-time equivalent GP. Capacity is particularly critical in Hanwell, Southall, and Northolt neighborhood areas. There are 4 GP practices in Ealing which have more than 5,000 patients per one full-time equivalent GP, and one each in Acton, Ealing, Northolt, and Southall neighborhood areas. But it's not just about the quantity of GP services we have. I think one of the key issues is also whether or not the GP practices we have are fit for purpose. The study suggests that the primary health infrastructure estate across Ealing is mostly old and non-compliant with current building design standards for the delivery of primary care services, for example, space and accessibility standards. It comprises small and medium-sized primary care premises, which are generally full or overutilized, and it requires investment in backlog maintenance, although premises are generally maintained at an acceptable level. Most households in the borough, approximately 68%, are within a 30-minute journey time to a hospital by walking or public transport, which again compares favorably to the England average of 37.2%. However, parts of Northolt, Greenfold, Perivale, and Ealing neighborhood areas have no access to a hospital within a 30-minute journey time by public transport. One of the things we're trying to address as part of this study is understanding what are the future requirements going forward over the local plan period. And the starting point for that is looking at the population forecast and how Ealing's population is likely to change over the next 15 to 20 years. According to the projections, Ealing is projected to need approximately 12,400 square meters of additional health infrastructure floor space over the next 15 years. And just to put this into context, our existing offices and customer service center at Percival House is almost double this, while the Ealing Broadway Shopping Center is 3.5 times the size. But again, as I mentioned earlier, it's not just about the quantity, it's also about the quality. It's about the premises being fit for purpose. And it's not just about the buildings, it's about the people as well. We know that the pandemic and Brexit had quite a significant impact on the NHS being able to recruit and maintain the number of staffing it requires. The delivery of this additional floor space is estimated to cost approximately £63 million over this period. And the demand for additional health infrastructure is going to be greater for acute health, followed by primary care, mental health, and immediate care. And I would like to point out that these figures are meant to be indicative at this stage because we are trying to project what the need is likely to be over the next 15 years. These figures will need to be monitored and updated on a regular basis to reflect any changes and any significant changes that could happen over this 15-year period. From a neighborhood area perspective, demand for additional health infrastructure floor space is projected to be greatest in Southall, followed by Acton. I mentioned earlier how the local plan can help shape the policies that can improve on our health and well-being outcomes. And one of them could potentially be the 20-minute neighborhood, which is the concept that people can access pretty much everything they need as part of their everyday life within a 20-minute walk. The 20-minute neighborhood approach can lead to numerous benefits, including health benefits, which could include reducing air and noise pollution, reducing the impacts of road traffic collisions, reducing severance and social isolation, improving access to healthcare, and improving local food environments. Economic benefits, such as creating new jobs, supporting local businesses, improving access to training and education services, as well as startups and shared workspace, as well as increased productivity. Environmental benefits, such as reducing reliance on fossil fuels for transportation, improving biodiversity, and social benefits, such as increasing sense of community and local pride, social interaction, and perceptions of safety. So not only can they have direct health benefits, but as we discussed earlier, they can affect some of the wider determinants of health, which are economic, environmental, and social. The health study is currently being finalized, and we expect to be in a position to publish it in July 2022. And we're committed to ensuring that the findings and recommendations of the study will help shape our future policies so that they can see a tangible improvement in health and well-being outcomes. So thank you very much for your time, and very happy to discuss further or to answer any questions.
Brilliant, thanks, Ilyas. There was a question in the chat about what climate resilience means, and given that the chat's not accessible to anyone watching, so Mandy, I don't know if you want to just, for the record, just explain.
Yeah, climate resilience. So, for example, the risk of extreme heat, the risk of flooding, these are some of the factors that are now form part of climate resilience. So high climate risk, high heat risk, high flood risk, etc.
Great, thank you. Joe.
Yes, I just wanted to check because I was in our board meeting today and they were presenting our trust sort of green plans, and I suppose I just wanted to check that you've got to join up into that work.
Sorry, could you repeat that, please?
Yes, sorry, I should introduce myself. I'm Jo Manley. I'm Deputy Director at West London Trust. And I was just saying, I was at the board meeting today, our trust board meeting, and there was a really interesting presentation about the work the trust is doing on its green plans. And I suppose I just wanted to make sure that you've got to join up into that work.
Yeah, we have tried now, we have a quite extensive steering group as part of this study that includes officers from Ealing Council strategic planning and public health teams, colleagues from the NHS, including the CCG and Hoodoo, for example. Neha and Mandy, who are on the call today, are part of the steering group. So we have tried not to be as inclusive as we can. Now, one thing I should mention about this study is that this is the first time Ealing Council undertakes such a study. And as far as we know, there is no template or guidance for doing this. And when we looked at what other London boroughs have done, we couldn't find many examples of other London boroughs doing this. So we appreciate that health is a very extensive topic, and this one study will not be able to cover everything, but we think it's a good starting point, and it's something that hopefully will need to be updated and continued in the future. And if there are other partners that we should include in the future, we'd be very happy to have a discussion and see how we can do that. In terms of this study, we are now in the stage where the consultants are finalizing the report. So I think there will probably be limited opportunity to get more engagement with other parties, but hopefully the CCG and Hoodoo will have provided a good representation of the NHS perspective.
Yeah, no, I think it's really good. I suppose I just was wanting to make sure we don't duplicate efforts, and we're all, I think everybody's going in the same direction, but it's just making sure we don't double up or that we work together on it.
Yeah, and I think Judith suggests send that work to Ilias, but I suppose we could also put you in touch with Joe Mortensen, who I think is our kind of lead on climate emergency issues. So that's probably a really helpful link to make. Thanks, Joe. Neha.
Thank you. So yeah, I've been very involved in this work, and I've read through a couple of the first drafts of it. And Joe, just to assure you, I did make sure that all of the providers, estates teams, and Chris as well inputted into the report. I can't confirm that the green bit was, but definitely around all of the estates teams across all of the providers. What's really interesting is I think, Josh, what you just described about all of us moving in the same direction is, well, sorry, Joe, all of us moving in the same direction. Today we had our borough committee as a CCG, where we also discussed, a workshop with our clinical directors, a piece of work being done by a consultancy company that's come in to look at the estate of all of general practice, but also some of our providers, and this state and the condition of the practice, and what the opportunities are or not for growth of those, and what it very clearly saying, and what this report also seems to be saying, is that we are really tight when it comes to estates. And I think we've done all of the easy things that we can do. We as a partnership need to think about how we're going to solve this problem longer term, because we are growing out of everything, and the population is increasing quite fast. We also need to recognise that we need to do a lot of work around workforce as well, of course, not just having the estates. We need the workforce to see the patients as well in those estates as well. But it's going to be interesting to see all of these reports reporting at a very similar time, saying a very similar message with a slightly different slant on it, and what we then do and what we take from that as well.
Right, yeah, and the good news is that obviously this forms essentially the planning rules for the borough, and says that, as proposals come forward, we might say yes, it should be given permission because it fits within what the health study has suggested. So it has this piece of work will have a tangible impact on that provision, so long as the investment is made available and proposals do come forward. So we shall see. Simon.
Yeah, I'll probably say similar to what's already been said, to be honest, because we are doing similar things. You heard about broader strategy. We're looking at our forecast of demand and what that means for space, etc. I'm not sure we're thinking necessarily in a significant increase in acute estate for ourselves necessarily. If you just look to demand, that might be the case, but we're also thinking about how we use our assets differently, both staff and equipment, and emphasis on more 7-day service and that kind of thing that might constrain the need for space. But it's definitely worth sharing some of the things that we are doing, not necessarily for this report, Ilias, but I think in terms of, so that we are capturing what we're doing, all collectively doing in Ealing. And I think maybe something like the event next Wednesday, when we talk about the Anchor organisation as well, that there will be some things that we're doing around workforce and procurement around that will also help support this agenda, I suspect, going forward.
Great, thanks, Simon. Are there any other questions for Ilias or comments? No, well, thank you, Ilias, for updating us. I think, as you say, that planning rules not necessarily something we would think of looking at Health and Wellbeing Board, but as you say, built environment has such a kind of, not just in terms of how much of it is given out to healthcare, but the way it shapes the borough, shapes the lives of the people who live in it. So really helpful update, and thank you for the hard work on the local plan health study. Thank you very much. So we move, I think, to our last substantive item, which is from West London NHS Trust to give us an update on mental health beds and particularly the Wolsey wing?
Okay, I'll just kick off. So I introduced myself earlier. I'm Jo Manley. I'm here today representing Chris Hilton, who would normally be here but is away in a rather luxurious, lovely, warm, sunny place. Yeah, we wanted to bring along the work that we've been doing around the Ealing acute mental health beds. I think my colleague Nitika Mahan, who is our Director of Transformation, is going to present in a moment, but also to introduce, I think Finn Larkin is lurking somewhere. Dr. Finn Larkin is our...
I am indeed. Hi.
Hi. He's our clinical director in acute mental health. So we've sort of come along as a team. But basically, we wanted to tell you a bit about the work that we are undertaking at the moment around the acute mental health beds. And we'd be really grateful for a steer on any further information that you'd like to receive on this work. And we'll tell you a little bit about the sort of the pathway, I think, in Nitika's presentation. But Nitika, I'll pass over to you because you're the expert.
Thank you, Jo. I'm going to cover the slides briefly, but really I wanted a really good discussion on this topic. So it was really helpful to have the previous presentation and hear about the healthcare estate condition, both for primary care and other healthcare services. I just wanted to echo what you put in the chat about mental health estate having similar challenges as well. And this work is very much about that. So I'm going to cover a little bit about what this work is. And then secondly, I'll cover how we've developed or are developing our proposals. And finally, we'll cover next steps. So in terms of introduction, I wasn't going to go through that, but this is a general overview of who we are and what services we provide. And in terms of inpatient mental health care, so relatively a very small number of people will experience an acute mental health crisis. And typically when that happens, they usually do require a short episode in their overall recovery journey within an acute inpatient mental health ward or a bed. Since 2013, we have provided cross-borough, that is across Hounslow, Ealing and Hammersmith and Fulham, single acute mental health inpatient service. And within Ealing, we've had previously had 31 beds within which, there were 14 male and 17 female beds in Wolsey wing. And the condition of that particular estate out of all of our inpatient estate was particularly really poor. It was one of our dormitory kind of provision and had lots of challenges in terms of us providing safe and effective care from that premise. And this was a fact that was routinely noted in our CQC inspection reports as well, that these wards struggled to meet the equality, accessibility, and quality standards that were required for safe and effective care. So in 2020, early on when the pandemic started, we've had to suspend the use of those 31 beds within Hope and Horizon wards, and also the associated one room, which was serving as a health-based place of safety within the St. Bernard site. And some of the colleagues who are on the call have seen the condition of that estate. And the main reason for us to do that at that time was around us needing to do something quite urgently to maintain the business continuity and service operations and have the right infection control measures for both for patients and staff members during the pandemic. We have fully ring-fenced the funding that we weren't using in staffing those wards. So in the summer of last year, we opened a new ward called Robin Ward, which is located in Hounslow and has 18 adult mental health beds, and it's a much more modern facility. And in addition, we've opened a number of additional services that are much more holistic and support users in various bits of their journey. I think the bit I really wanted to highlight on this particular slide is that we are still committed to a wide range of services across Ealing's and as well as on St. Bernard's side. So you'll note that we continue to have 246 specialist forensic and low medium secure mental health beds, 38 older adult mental health beds, 17 recovery beds, which are step up and step down kind of provision. And besides that, we have 70 beds at Clay Ponds, which is non-mental health community rehab sort of facility. Since we've suspended Hope and Horizon, the Wolsey wing continues to host the services that were previously there, including crisis services, mental health single point of access, and also our perinatal mental health services. But the inpatient aspect of that provision has stopped in that wing. In terms of our current position, as I said, we haven't made a decision, but we started a piece of work around August 2021 to really try and see how we develop a proposal that would enable us to make a decision on the future of Hope and Horizon wards. And this work is very much linked to some of the national, regional, and local drivers, which I have listed here. And it very much aligns to the, one of the previous clinical model of care that was endorsed within Northwest London for mental health patients, which is very much about enabling patients to live a full and healthy life in the community and spend as little time as possible, but through having very effective care within the acute inpatient facilities. So over the next couple of slides, we've just put in some more details around our quality case for change, our capacity case for change, and also the transformation of services that we have undertaken. I wasn't going to go through that in detail, but one of the things that I thought it would be worth highlighting in terms of our quality case for change is that when we have looked at the data and done quantitative analysis of who are the patients who were using Hope and Horizon wards, we realized that residents within the borough, they would probably benefit from a greater access and support for their mental health needs earlier on in their pathway. So one of the findings we had was that some of the people from Ealing, especially from BAME communities, were overrepresented in terms of their use of inpatient mental health care and underrepresented in terms of use of their community-based mental health care. And we think that providing interventions early on in a patient's journey is much more effective way of providing support and care to them. The other thing I just want to say that we've done quite a lot of detailed work on travel times since the suspension has taken place. And I recognize that while the averages aren't very significant as shown here, but there are certain postcodes, especially in Greenford and Northolt and Hayes, where the actual difference in terms of the journey times for patients and carers is longer. Therefore, in terms of our solutions within the proposal, we're very committed to developing and putting in place some sort of transport arrangements for patients and carers so that they're able to access the services. I just wanted to talk slightly about how we benchmark against other trusts. So this is our this is from our last published benchmarking report. And as you can see, the trust has about 20 beds per 100,000 weighted population and benchmarks slightly higher than both the national average and London average. And I've also put in there the range across different London providers. In terms of data analysis, so we've looked at quite in fair bit of detail, the data from last 3 years in terms of use of inpatient beds from across the 3 boroughs. And there's clearly some variation in terms of patients being admitted from different boroughs and their lengths of stays, etc. We have also looked at some of the other indicators like readmissions and can confidently say that the readmissions have remained low, and we have managed a length of stay of around 40 days in the data that we have analyzed. We've also looked at some predictive demand and capacity modeling, And the table that you see here on the slide shows quite clearly that if we continue to operate within the 40-day average length of stay sort of work baseline that we have been managing on, then we have enough beds within our system and will continue to have enough beds in our system. But there's obviously scope for improvement. I think some of the national bodies, they do talk about 32 days length of stay as being optimum for our patient groups. And we think that if we can optimize our length of stay further, then we will be well within the beds that we currently have running within our bed base. I just wanted to say that in this analysis, we've not just looked at the averages, but also we've looked at the daily variation patterns, etc., that we're likely to see over the coming years. I think the board would be interested in noting some of the engagement that we have done throughout the development of our proposals and how it's shaped up so far. And this slide gives an overview of number of individuals we've reached out to and the organizations we've spoken to. And we have throughout this process really listened to people to understand what factors are most important for them to be able to access the services and have a safe and effective experience of the care that they receive. And that has really shaped the long list of options that we developed, options appraisal criteria, as well as the shortlisting process. In terms of where we are now, so we are at the moment sort of in the process of shaping up our proposal that we have developed over the last 9 months or so, and we have developed a very detailed equality, health inequalities impact assessment, both from staff and patients, patients and carer point of views. And we're hoping to bring it back to the Ealing Scrutiny Panel that is meeting in September, and also the Health and Wellbeing Board, which is also meeting early September. Within that proposal, we will very much outline the process we have undertaken, our case for change, as well as some of the solutions we are committed to put in place for this solution to work. So I'll open the floor to any questions. Sorry, I can't see any hands.
No worries. Thank you, Natika. That's a really helpful presentation and a vast amount of data, which is really helpful. Daniel's put a question in the chat about what you credit with keeping readmissions low.
Thank you. Sorry, can I just see the question? And I would also like to invite Finn, if he would like to respond to this question, please.
Yeah, I mean, thanks, and thanks for the presentation. I think it's very helpful. So it's multifactorial. We are very tight on our immediate follow-up from discharge. So our kind of immediate follow-up, because that's quite a risky period, and the transitions across to community services. We try and have good treatment plans in place prior to discharge that are maintained. And I guess whilst life is never perfect, we seem to be doing very well on that metric, which is a good thing. You don't want your readmission rates to be zero, because that would suggest you're being overly restrictive and you're not letting people out as soon as they're reasonably ready. But so it does go up and down a little bit, and it's not something that we'd want to be an extreme outlier in. We're in the kind of higher performing side for that metric, and that's about the right place to be ethically, I think. So.
Great, thanks. Kerry.
Thank you, and thank you for the presentation, Natika. I think the question from my perspective is with regard to the cost of living crisis and the increased levels of mental health and ill health we're seeing within the community. Will the numbers be kept under review, as we're expecting to see some increase in impact on people's mental health and well-being within the community?
Yes, absolutely, and we're keeping a close eye on the need for mental health services within the borough, and if we're experiencing any spikes in demand, etc. I just wanted to add that we have put in a number of services at the front end of the pathway, especially around support for those who are starting to present with a mental health crisis. as well as more services towards the later part of the pathway, when people are ready for discharge and need to be supported to stay well in the community as well. So of course, we will be tracking the numbers over the coming months, but we have been able to manage a reasonably good position for over 3 years now, and we're confident that we can continue to do so in future.
Thank you. And Neha.
Thank you. So we went to see, Vijay and I went to see the site last week, and it was awful. I wouldn't want my family member to have to go into an area like that. Very small windows, no natural light. Just didn't feel like an environment where you can really improve on your mental health, to be honest. I really welcome the commitment to that ring fencing of the funding to help with the pathways more earlier on in the pathway, and then support back out into the hospital, so into the community. So I really welcome that.
Great, thank you. Joe, I did see your hand go up. I don't know if you had wanted to add something.
I think Niska probably answered it. I mean, I just pick up Kerry's point, all this sort of out of hospital obviously care depends on our good partnership working and how we work together to provide services outside the hospital, and our partnership with the local authority in Ealing is excellent, and thank you for all the support they give us. But I think you're right to talk about the economic change, the pressure of mental health on our service users, as well as probably the pressure that we're going to see on our own services. So I think, as Nitika said, we will be constantly reviewing that, but I think it's right to raise that as an ongoing risk. Great,
thank you. So as I said, that's a really helpful presentation. It's a huge amount of detail. I think, like Neha, I'm visiting. I know I did a slightly virtual walkthrough because of diaries some time ago, which whether they are good for mental health beds, they're not good for Wi-Fi, the rooms, I can tell you that. But I will be visiting shortly as well, so that's really helpful. Is there anything, so I think the second point on the first slide is whether there's any further information that we'd be keen to receive about this. I know certainly there was mention, I think you said about engagement with BME communities, and I can't, yes, review, publish local and national reports on access and experience by specific equality groups. I think it would be really helpful to see some equality impact assessment kind of data on this.
Absolutely.
I think given the postcodes affected, we can make assumptions about the populations, but it'd be helpful to see that just in a little bit more clarity, just so we know what the impact will be. Obviously, for, as you highlight, particularly on disability, it will be a positive that these beds are not being used, given they're just not suitable. Vijay.
Sorry, my hand function keeps intermittently going on and off. So, yeah, I just wanted to just echo what Neha says in terms of in terms of the site visit we undertook last week, and it was apparent from the outset that the current internal configuration layout of both of those wards it is not fit for modern practice. In relation to the facilities for the individuals that are inpatients within those two wards, but also the ability for staff to monitor the inpatients as well. It has a very archaic way of monitoring patients, and it's really not fit for modern clinical practice. And looking at the structure and the layout of the area, even if you try to invest money in terms of internal reconfiguration, it just wouldn't meet the standards that one would expect. But my other question is around in terms of the residents of Ealing, I think it's important, particularly in relation to the step down beds and the recovery beds, that I think it's important that for Ealing residents that once they've been stabilized in an acute inpatient setting and they do require recovery step down beds, that they are prioritized back into the Ealing borough in the Ealing beds that we have, because I think that will then help to facilitate their ongoing recovery from that acute episode. So I think we just need to be mindful of that and try and ensure that is maintained going forward. And in terms of the ring fencing of the investment, I definitely certainly welcome that. And if there is scope for further potential to have recovery or step down beds within the borough, if that need is there, then that is most welcome as well.
Right, thank you, Vijay. Any final comments on this one before we then? No, so we can note the update. Thank you very much. And I know you say you'll be back, not just with us, but with the scrutiny panel as well, which is really helpful in terms of engagement. So thank you for the proactive engagement on this as well. It's really appreciated, not just from the council, but from the political side as well. It's really helpful to get that engagement. So I think that brings us to the final few bits. I don't think we need to cover the Health and Wellbeing Board work programmes. I think we had that earlier in terms of the workshop that's happening next week, to which London Northwest are definitely invited in some way, shape or form, and we'll get that to you. And we haven't had any questions from members of the public. So thank you all very much. Big solid agenda, and we have got through it almost exactly in 2 hours. So thank you very much for your contributions, pithy and to the point, very much appreciated. The next meeting, I think we've already mentioned, will be in September on the 7th, but I'm sure I will see some of you next week